you're blocking the estrogen receptors on the pituitary and the hypothalamus, and thus luteinizing hormone and follicle-stimulating hormone levels go up, which stimulates testicles into testosterone production and spermatogenesis. And this sounds very, very appealing on paper. Let's say you did your testicular ultrasound, you don't have a varicocele, your testicles function properly. There's something you can look into. That's human chorionic gonadotropin, HCG, monotherapy. You can do that with subcutaneous injections, albeit that the clinical literature usually goes with intramuscular injections. From my personal experience, I never really noticed a difference between intramuscular and subcutaneous administrations. And since intramuscular administrations over time, we're talking about decades here, even with insulin syringes, will build up scar tissue. I have a lot of experience with scar tissue doing bodybuilder cycles, so I would not recommend it. Nowadays, if I had a time machine, I would do everything sub-Q. So that goes for human chorionic gonadotropin, but also hormone replacement therapy. I would administer, based on the clinical literature, between 250 IUs to 500 IUs subcutaneous daily, every other day, or tri-weekly. And it really depends on what you want to accomplish. Because I have let me overlay one study here. You see in this study, post-treatment with post-treatment of HCG monotherapy, intratesticular testosterone was 25% less from baseline in the 125 IUs HCG group, 7% less than baseline in the 250 IUs HCG group, and 26% greater than baseline in the 500 IU HCG group. The results demonstrate that relatively low dose of HCG maintains intratesticular testosterone within the normal range in healthy men with gonadotropin suppression. Now, this is in the context of not taking hormone replacement therapy. So if you go to do, HCG monotherapy, then you already see that from a dose of 250 IUs, you get sufficient levels, which is comparable to baseline. And then as you ramp up the dose, 500 IUs should give you 26% more. And when you look at fertility studies that go up to 1500 IUs, testosterone levels are significantly higher compared to baseline. Now, you'll have to decide, based on what you discuss with your primary healthcare physician over at Merrick Health, if that's going to be daily, every other day, or 3 times weekly. Personally, what I'm doing right now is 1,000 IUs HCG 3 times per week, Monday, Wednesday, Friday. My testosterone right now is 850 nanograms per deciliter. And without this HCG monotherapy in place, I think my testosterone levels would be around 600 nanograms per deciliter based on previous results when I came off steroids completely. So this is a significant difference. This is an increase of 35%. Just keep in mind that I'm 40 years old and I have some steroid cycles under my belt. So some people might get significantly higher testosterone on 500 IUs HCG 3 times per week as monotherapy, right? These are all considerations for you to, try and discuss with your primary healthcare physician before you start testosterone replacement therapy. There's also what is very popular nowadays is Enclomiphene monotherapy. This is taken orally, so you don't have to do any injections. That's daily, every other day, or 3 times weekly, and the dosages range between 6.25 milligrams to 25 milligrams. What difference between HCG and Enclomiphene is that HCG simply stimulates the testicles, replaces the luteinizing hormone signal that your pituitary would send to the testicles. LH and HCG work on the same receptors. As a result of that, LH and FSH levels probably come down. So you still have pituitary downregulation. You're shut down, but the testicles are still active because you're stimulating the production of testosterone and fertility, spermatogenesis downstream with this medication. Whereas with Enclomiphene, you're blocking the estrogen receptors on the pituitary and the hypothalamus, and thus luteinizing hormone and follicle-stimulating hormone levels go up, which stimulates testicles into testosterone production and spermatogenesis. And this sounds very, very appealing on paper, but the problem is that selective estrogen receptor modulators have various negative side effects. One of them, the most worrying in my opinion, is the potential for clotting risk. Now, when you start doing research, you see that Clomid has clotting risk. You see that tamoxifen, Olvidex, has clotting risk, raloxifene, tormifene, but not Enclomiphene. And since Enclomiphene is a reasonably new selective estrogen receptor modulator, it is part of Clomiphene. Clomiphene is about 2/3 Enclomiphene and 1/3 zuclomiphene. They're stereoisomers. So the molecular structure is exactly the same, but they're folded different. And enclomiphene is the one that increases luteinizing hormone and follicle stimulating hormone. And overall, the most positive effects are coming from the enclomiphene regarding the functioning of the pituitary and the hypothalamus. And it's zuclomiphene that allegedly gives the most side effects. The problem is it hasn't really been investigated that much separately. So enclomiphene has about 100 studies or up to 100 studies that you can do research on. In the clinical literature, you see a lot of case reports, and it's well established that clomiphene has clotting risk, but none of this has been disproven with enclomiphene. So I would always proceed with caution. Maybe look into your clotting factors, maybe do a CAC score, right, to see if you have a coronary artery plaque buildup, because nowadays you can't be too careful about clots, unfortunately, right? That's not through anybody's doing. That's just the world that we live in nowadays. So now that you know, please discuss this with your healthcare provider. Even though the administration is significantly easier, a lower barrier of entry, I feel that based on all the research that I've done, that the risk is a little bit higher compared to HCG monotherapy. And well, otherwise I would run enclomiphene right now and not HCG. So keep this in mind. Next one, when you're ready, right? You tried HCG monotherapy or enclomiphene, your testosterone levels came up slightly, but you're still not happy. And you want a little bit, try something new, right? You want to see what's behind door number 2. Then testosterone replacement therapy is probably an option. Testosterone replacement therapy is, again, like I mentioned before, not just testosterone, it's hormone replacement therapy. That's testosterone, human chorionic gonadotropin, dihydroepiandrosterone, and pregnenolone. And DHEA and pregnenolone are both neurosteroids that aren't always required. And this is why very important to do your blood work. Because, of course, DHEA and pregnenolone levels also decline with age. But you see in a lot of younger individuals that do everything right. They're healthy, they go to the gym, they sleep properly, they're low stress, already graduated, or they're in a good relationship. You see that their testosterone levels might still be low, but their DHEA and pregnenolone levels might be sufficient. And when they try HCG monotherapy or enclomiphene monotherapy or testosterone replacement therapy, in that case, testosterone levels come up, obviously, to, let's say, the 2/3, 3/4, or top of the reference range, or slightly over that. That DHEA and pregnenolone doesn't move. Their adrenal glands still produce sufficient amounts of DHEA and pregnenolone, and they don't need to go the supplementation route. But as you get older, just like testosterone levels decline, DHEA and pregnenolone levels decline also. So maybe by the time you're 30, you notice that DHEA and pregnenolone supplementation is required. Maybe it's only DHEA. Maybe it's only pregnenolone. This we assess with blood work parameters, and again, something you have to discuss with your healthcare provider over at Merrick Health to see which of these options is the most the most relevant to you as an individual. So once you got that under control through multiple blood work analyses, then you might have to put lipid management in place, or blood pressure management, or estrogen management, but we'll get into that a little bit later on. So let's discuss testosterone first.